embedded, the boarding policy was introduced, an additional bed was put in B Bay. The outcome was Natalie became responsible for a much larger bed base, often up to 28 patients. The nomination goes on. Dr. Jenkins took over the role of consultant geriatrician ongoing under a much pressurised time for Wye Valley, and especially for Frouty. She was a fairly new consultant, but she embraced this challenge with great grace and strength of personality. Nothing was too much trouble. She was always positive and supportive of all members of the multidisciplinary team. She was caring and compassionate to all her patients and their relatives, able to explain why they were being nursed in a corridor at times. She was always accountable for decisions on the ward and supportive to the rest of the team at difficult moments. She showed the utmost respect for all members of the team and helped us all provide excellent care at some of the most difficult times the NHS in Hereford has had to cope with in recent years. Natalie, you're an absolute star. Thank you very, very much on behalf of everyone, all the citizens of Herefordshire and our board. Thank you very, very much. Our next employee of the month is for March, and I think I've got Lucy with me. So Lucy, thank you for joining us. Lucy, your nomination goes on. It's like War and Peace, your nomination. So bear with me and I will try and get through it, but I may sort of simplify it a little bit. So it's lovely. It says Lucy is incredibly empathetic and compassionate and has been a consistent source of kindness and support over the last few years. She is the most supportive manager that I've ever had. She takes the time to regularly communicate with us all as a team. She is quick to address any concerns which are raised and is constantly striving to make things better for both staff and service users. She always takes the time to offer praise. She is accountable in all her roles as a direct line manager and as a joint head of service. She ensures that we're all safe. She continually goes the extra mile, both in terms of supporting staff on a personal and professional level, and in terms of improving the service. She has always supported the needs of myself and the rest of the team and actively listens to our concerns. She has responded positively to suggestions for new or more flexible ways of working. She has demonstrated excellence in her role as a manager and has gone above and beyond to offer support to myself and the rest of the team. What an absolutely lovely commendation. Lucy, there's clearly a lot we can all learn from you, but very well done. You're our Going the Extra Mile Employee of the Month for March. Well done, Lucy.
Thank you so much.
To move on then to the Team of the Month, and the Team of the Month for March is our PALS team, and Shirley, and in the background I think lots of other colleagues, so hi Shirley. So I will read out the nomination for all of you. So it reads, at a time of increasing operational pressures, with long waits for patients, often angry, upset and distressed patients and families and carers who are increasingly contacting the PALS team. Their issues are wide-ranging, but one thing becomes more predominant is the need for immediate resolution to answers or to questions. People are tired of waiting. On a daily basis, the team go above and beyond to support patients and their families to resolve these type of issues. Speaking to colleagues across the trust, visiting patients on the wards and even conducting searches for patient property. The emotional impact of communication from distressed people in recent months has taken its toll on the team, but it does not stop them from doing everything within their power to help. In a lot of cases, coordinating patients' concerns on their behalf, even if it's not Wye Valley Trust's responsibility. They know that patients can find navigation of our healthcare system difficult. Rather than passing them on to other organisations, they reach out on the patient's behalf to seek answers to the questions. The team also respond to staff concerns about patients, reaching out before they feel the need to raise a concern building a relationship with the patient and helping them to be reassured that their healthcare needs are being met. The nominator says, I could not be prouder of how resilient and caring the team are when faced with increasingly challenging discussions on a daily basis. The team embody all our trust's values. Shirley, you are very much at the front line when things are difficult. You and your colleagues, please pass on our thanks. Hopefully they can hear what I'm saying. I'm incredibly proud to have you and all of our PALS team doing such wonderful work. On behalf of the board and our citizens, thank you very, very much.
Thank you. I'll pass that on to my colleagues who aren't here, but we really appreciate the award.
No, it's wonderful. And just as a general point, I know that all frontline colleagues are having a really tough time at the moment with the different strikes that have been ongoing, as well as the phenomenal increases in demand that we're seeing. We know things aren't easy, but we really do appreciate all of our staff, but the ones who are exceptional, we do love to sort of celebrate in the Going the Extra Mile Awards. So you're very welcome to stay for the rest of the board if you'd like. If not, we will understand that you may have other things to do. Now we've got a pretty straightforward agenda, I think, today, but we'll start off with the minutes of the meeting held on the 1st of June. Were there any points of accuracy on those minutes which colleagues would like to amend? Could you please raise a digital hand? Okay, I can't see any digital hands raised, so we'll move on then to matters arising. And the first was around the staff survey results, and that's on the agenda, so we'll come back to that later. Thank you. Then on workforce, Jeffrey to provide an update on pharmacy recruitment. We had a big session this morning as a board in our workshop where we covered the whole issue of workforce, and in particular with Tony had a deep dive into pharmacy. We are very aware of the real recruitment challenges nationally and locally on pharmacy, so I would like to just have a shout out to everyone who works in our pharmacy services for going above and beyond on a day in, day out basis to do what they can. We know you are very short staffed. It is a national problem, as you're aware, but we are trying to do our best with colleagues in Worcestershire as well and across the ICS to address the system as quickly as possible. In terms of finance performance, Katie will review what our agency figures in terms of our pay bill need to be on average each month. We come back to that, but the rough number is 6.8% a month, isn't it, Katie? And we're still running a bit above that.
Sorry, I couldn't come off mute there. Yeah, absolutely. Across the full year, it's 6.8%. The plan is phased in a way that at the start of the year is higher than that, and it gradually reduces in line with some of the targeted actions that we're taking. Okay, great. And then the final action point, which is in progress, is about the ongoing work we're doing on culture to try and improve our staff survey results. So Jeffrey, please keep us briefed on all of that. So, are there any matters arising the colleagues feel I've missed? What I have missed is welcoming new colleagues onto the board. So absolutely delighted to have Kieran, Ellie and Sharon as our new associate non-executive directors joining us today. Being a non-executive director in the NHS or any senior position in the NHS is not easy, but it is incredibly important in terms of helping us serve the citizens in our geography. So really delighted to have the three of you joining us. Hope you have a wonderful time, and everyone at Wye Valley is delighted to have you on board. So in Glenn Burley's absence, Jane Ives is bravely going in to summarise the Chief Executive's report. So Jane, over to you.
Russell, I'm only pleased that he wrote it. NHS was 75 years old yesterday, and the executive team members went out across every bit of the organisation yesterday, talking to staff. We gave out some birthday cards to celebrate the NHS, but also to thank staff as well. And it was really nice to be out and about. And one of the areas I went to was pharmacy, actually, and there's a really good spirit. So we know how much pressure they're under, but there's really good spirit there, and lots of other places as well. And it did coincide with the publication of the National Workforce Strategy, so long awaited, long delayed, but it's here now. And there's an awful lot in it, and there's an awful lot to like about what's in it. I mean, there's a few things that are missing. I mean, it doesn't really deal with the issues around the ongoing industrial action that we've got. It doesn't really mention capital as part of the funding. But that said, there is a huge amount in there, and it very much aligns with the strategy that we were talking about in our workshop this morning about how we grow our own staff, and particularly how we use apprenticeships to do that, with a huge expansion of apprenticeships options into careers in the NHS. So I'm going to be good to really take that forward as we go over the next 10-15 years it's for. Further Faster, so it's a national programme which we are part of, which are some hospitals which are aiming to get there more quickly in terms of reducing the waiting times, particularly in outpatients. So we've had really good clinical engagement from all of our teams. It's done specialty by specialty, sharing good practice, promoting good practice. So we've had some really great engagement with that, and it aligns with a lot of work that we've done across the group in the past in terms of sharing good practice between different specialties. Although the priority is outpatients under that programme, and we're really looking at tackling theatre productivity. And at the beginning of this week, we started a new approach to that. So a number of executive and non-executive colleagues are spending some time in theatres, being critical friends, observing what's going on, looking for opportunities. I had my session there yesterday morning and watched a very exciting knee replacement. But there's real opportunity for lots of small marginal gains for how we improve productivity through our theatres. So this is really a fortnight of intensive activity to really fire the starting gun on a whole range of things to improve that. Glenn mentions about the National Urgent Emergency Care Recovery Plan, and we've got that on the agenda later, which is our element of that, which is our sort of preparation for winter, and Sarah Parry will be talking through that later, but it includes all of the things that are in the national plan. CQC visited us in the last week or so, and we've had some informal feedback. We'll obviously bring back the formal feedback when the report comes through in the next month or so. But I guess the headlines on that were some really good feedback about the strengthening of the leadership team we've got in maternity, which was really good feedback to hear. But some misalignment between our policies and our practice. So our practice being good and aligned with best practice, but our policies being a little bit out of date. So a lot of that has already been resolved. So we await the result of the whole inspection in the next few weeks. Last thing I wanted to mention was the National Volunteering Task Force, but really a thank you to our volunteers. We have some absolutely brilliant volunteers, particularly around bringing some of our younger population into volunteering roles, which has gone really well. And we've had a number of examples of those young people doing volunteering and then starting their career in the NHS. So that's been really good practice here. We are mentioned in the national report for that piece of work. The last thing in the report then is just the highlights from the medical division, covering a number of those issues around urgent care.
Thank you very much, Jane. Any questions or perspective on Glenn's report? Okay, Glenn is actually down in London today meeting with the Prime Minister, which is a really great level of profile for us as a foundation group and for Wye Valley. Just one thing for me to add, which is in my excitement, I missed out the team of the month, which was for February, the cleaning team of Sharon Davis and Claire Honeybourne. I'd just like to have a big call out, to be honest, to all of our support teams behind the scenes, whether it's our cleaners, whether it's our receptionists, or whether it's our security staff, who are often unsung heroes, who do phenomenal work. But for Sharon and Claire, it was written, both of these housekeepers have demonstrated support for all areas of the medical division to provide additional training to other housekeepers requested by the ward sisters to enable areas to be more organised and flow with stock. When short-staffed, both support with patient care, showing excellent teamwork and keeping morale and motivation going. So Sharon and Claire, thank you very much. And thank you very much for everyone who behind the scenes do such great work to look after our patients. Our colleagues, happy to move on to the integrated performance report. And Jane, again, do you want to introduce this, please, and we'll get into the detail?
Will do. I won't cover the points I've just made around urgent care under Glenn. So I mean, I do a monthly leaders briefing, and the theme for the one a couple of weeks ago was making hay whilst the sun shines, because really we've got a bit of a window of opportunity over the next 3 or 4 months before we get back into winter again to really make sure we've done as much as we can to prepare for winter, but also as much as we can to improve our productivity. So there's an awful lot of focus on both of those things that's over the next few months. And I think one of the things I try to do with this report is try and sort of join the dots a little bit between the various reports on the aspects of what we do from the directors. And one of the sort of the dots I've joined together this time is, if we look at what happened last winter and the extraordinary pressure that we and the rest of the NHS, but the extraordinary pressure that we were under, I mean, say at its very worst, we had an additional 100 beds to our normal 300 acute beds on the Hereford County site. And we can track the increase in pressure damage that went alongside that pressure. So it does real harm to patients when we haven't got the capacity to deal with needs in the way that we normally would. So we are doing absolutely everything we can in the hospital with our community teams, with our partners, to make sure we've made our pathways as good as they possibly can be and get the capacity in the right place. One of the opportunities we've got is the delegation of the Better Care Fund to One Herefordshire to be managing the resources that are within that fund and redesigning the services that are under that fund. This is a joint fund between the NHS and between local authorities, and so we're not quite there yet with it having it agreed. It's going to be within the next week or so. I'm confident it will happen, and then we've really got an opportunity through those the integrated assurance we've got, particularly through the integrated care executive that Francis chairs, to really drive that joint funding to create much better and slicker discharge pathways. So it's an opportunity that we've got, and again we've got to get the work done over the course of the next 3 or 4 months so that we're prepared for winter. Things I'm worried about, I think probably our cancer performance is the thing that's worrying me most at the moment. Generally, the trust has been in the top third of cancer performance on the 62-day standard, but we have dropped in the last couple of 3 months. Generally, that's around the diagnostic pathways. So lots of effort going into that. I mean, Andy updated on that last month, and it's not going to be a quick fix. But I think that is one of the things that is worrying me, that we're not doing as well as we were. Some of that is related to demand, as I say, some of that is related to diagnostic capacity. On the good news side, though, I mean, we reported last month we'd started to see a turn on our HR metrics, and they have certainly improved again this month. So Jeffrey will go through those, but we are on course, and Jeffrey might be able to tell me whether it's true, but we were looking to be under 4% for sickness in June, and I don't think I've ever seen it that low. So there's been an awful lot of work across our management teams, engaging with staff and making sure we put all those health and wellbeing things in place to keep staff at work, and that does seem to be paying off. It's not a one-off this month. It's a trend over the last 6 months. And then the last thing I think I'd draw attention to is stroke mortality. We know that this is one of our fragile services, and we have got a briefing on that in the private board. But we have been in the top 1 or 2 on our SNAP, which is a stroke process measures audit, which is a continuous audit, and we've been in the top 1 or 2 in the region for many months, and that does feel like all of that is coming through in mortality rates, and so we are in the top 10 in the country in terms of our mortality for patients who've suffered a stroke, which is some pretty exceptional performance, actually. Okay, that's it, National.
Thank you very much, Jane. Questions or perspectives to Jane? Jane, it's important, and I know you do this anyway, but I just want to state it for the record. It's very important we're self-critical of ourselves. So the talk about the harm which comes out of us having to work at such a level of pace, and with the challenges that we had due to the demand, it's very important that we're very open on that. And I would just make an additional point in terms of encouraging. We have a very good record at Wye Valley of colleagues speaking up if they've got an anxiety, and I would really encourage any colleague to use the freedom to speak up channels if they need to, or to make their line manager aware of any anxiety they have. We know things are tough, but at one level, a problem shared is a problem halved, but it is important we all understand the scale of the problems we're facing. Our colleagues happy to move on then into quality and safety. Lucy, are you going to lead and then Robbie follow?
I certainly am, Russell. Thank you very much. So 3 things from me, and then I'll hand you over to to Robbie, who'll talk about VTE and mortality. So I'm going to take the report largely as read, but include in the report just the year-end position for the commissioning for quality and innovation, the Sequin programme. 6 sequins as part of our contract this year, and you can see really strong performance at the end of the year for 4 out of the 6 sequins. The 2 where we didn't achieve, we were in line with the rest of the NHS around the vaccination of frontline workers for flu, and that's felt to be due to what the NHS is calling vaccination fatigue for frontline staff, given the number of vaccinations that individuals needed to have throughout the pandemic. We ended up sort of middle of the pack in the NHS for our flu. And although we didn't achieve the pneumonia sequin, we missed it on one element only, and that was documenting the severity score, which we've now addressed through a prompt and a change on our electronic patient reporting system within ED. But the 2 elements that are of primary importance are timeliness of X-ray and timeliness of antibiotic administration, which we achieved thoroughly in that sequin. Jane's already alluded to it. I am worried about pressure damage. That's avoidable pressure damage, i.e. pressure damage that occurs in our care that we could have avoided. And although the numbers are low, they're higher than where we would want them to be. We know there's been an increase nationally, but actually we should aspire to eliminate all avoidable pressure damage. We pulled together a quality improvement plan and presented that to Quality Committee a couple of months ago. But I've now established a working group which has been led by one of my associate directors, whose job is to ensure oversight of that improvement plan, traction and speedy delivery of actions. And their focus currently is around the education, training and clinical practice of frontline workers, and in particular a focus on those patients who might spend longer than we would want within our emergency department. And then finally from me, I include in the pack just a little bit of information around one of this year's quality priorities, and that's ensuring that patients receive timely critical medications. I mean, clearly all medication is important, but nationally there are a number of medications that are deemed to be time critical. So we've looked at the national list, and then we've developed our scope based on local intelligence and have selected 4 medications that we would wish to focus on, which is insulin for the management of diabetes, antibiotics for the treatment of infections and in particular sepsis, and opiates, so strong pain relieving medication. And additionally, we've signed up to the national campaign, the National Parkinson's campaign, which is called Get It On Time, given the time critical nature of delivering Parkinson's medication. We've signed up to that national campaign along with our foundation group colleagues at George Eliot and Swift. And given that focus, we undertook a baseline audit in May of our performance around giving Parkinson's medication. And actually our performance is really strong, but there's always room for improvement. We will report on that quality priority through to Quality Committee on a quarterly basis and up through to board as we progress with that throughout the year. And I'm going to hand over to Robbie now. Thank you.
Thanks very much. So I'll start with mortality. So the headline figures really are that our standardised hospital mortality rate is dropping. And that's in line with our reduction in crude mortality rate, and we consider this will drop further as the previous spikes that we can see within the graphs fall away historically. Particular improvements of note are around fractured neck of femur, and we've talked about stroke as well. That's in the top 10 now, or the bottom 10, depending which way you look at it, of the country. We continue to have issues around our palliative care coding, so there is ongoing work looking at that, because we think that impacts upon almost certainly impacts upon our overall mortality rates. And how they're calculated. And the other area is heart failure, where there's been a drift up. And so the cardiology team over the next couple of months are going to look through relevant sets of notes to see whether there's any learning that can be identified, whether it's a coding issue, etc., as we have done previously. For those eagle-eyed of you, on the last sentence within the report, there's a reference to an appendix which doesn't exist. Effectively, that's just around some of the other areas that we've been looking at in terms of learning from deaths. There's a piece of work being undertaken across all the deaths from ED, or those that have had concerns outside ED, which will help us identify any of the issues that we face, as we've discussed, in terms of congestion within the department, boarding outside the wards, etc. So I think that's probably a sort of summary of the mortality position. So overall encouraging. Does anybody to take questions about that now and then move on to VTE, or do you want to carry on?
If you carry on, Robbie, and then I'll take questions.
Okay. So in terms of VTE, probably the thing to say is that we're now in quite a good sort of business as usual. It's taken us a while, as you know. We did have a backlog of looking at our hospital-acquired thromboses, and we had to put a lot of new processes in place to try and get back on top of that. With all the work we've done with quality and safety across the last 18 months, 2 years or so, we are now, actually probably 2.5 years, we haven't had any recorded avoidable hospital-acquired thromboses at all since the beginning of last year. We have developed a little bit of backlog again on second review of hospital-acquired thromboses because of the implementation of in-phase, but we'll get back on top of that fairly quickly. In terms of our VTE assessments, we're still running below the national standard of 95%, and that's but what is encouraging, as we know anyway, that even if you don't have an assessment, almost all our patients end up with the appropriate prophylaxis. The two are disconnected, and not having had an assessment does not really equate to an increased risk of hospital-acquired thrombosis. However, it is an external standard. We know that the CQC have been looking at it, and it is good practice in terms of ensuring that the correct prophylaxis is used. There is now some work having been done. There's a model set up where Maxims and our prescribing module are now linking together, so that you can only prescribe the prophylaxis if the assessment is done in the first place. And I'm just going to work with the PMA team around that, and hopefully within the next month or so we should be able to link those, which then should hit our 95%, I hope. Right at the end, we've always tried to get to VTE exemplar status. We've hit almost all of those criteria now. The only one which we haven't hit, which we need to before we can apply, is the 95% standard. So I'm hoping with this change that I've just discussed, we actually might be able to in a position where we can apply and join the other sort of 30 or so organisations across the country in a VTE exemplar status. So that's VTE.
Thank you very much, Robbie. Swift are having the same issue on palliative care coding as well. Questions or perspectives to Lucy and Robbie. Francis?
Thank you both of you. Very comprehensive report and broadly very positive movement on all the metrics. Just wondering, Lucy, what we can do about avoiding vaccine fatigue for this winter. So sure as eggs is eggs, we're going to be into a vaccination programme in the next couple of months. So what's our approach going to be to encourage all of our staff to protect themselves, their families and our patients?
Thank you for that, Francis. So we have had the notification of obviously the flu campaign. We've been notified of that already, although centrally there's silence on whether there will indeed be a COVID vaccination but for the autumn as well. I'm surprised that they weren't issued together. Our learning from last year is, given the timing of the receipt of the flu vaccines and the receipt of the COVID vaccines, we went ahead with flu earlier than COVID, or the other way around. Forgive me if I've got that the wrong way around. And our learning is we should have waited. We should have held tight and delivered the vaccinations together rather than setting the campaigns off separately. So we will learn our lessons from last year as we move into the planning phase, which will be in the next couple of months, Francis.
Great, thank you, Lucy. Sounds very sensible. And Grace, and then we'll move on.
Thank you, Chair. Thanks both for a really clear report. Just in terms of timely critical meds, I'm really glad to hear the strong performance and insulin's included. Is there plans to expand that into timely critical meds for Addison's and adrenal insufficiency, or is it not in line with the local priorities?
So at the moment we want to focus on those 4 medications, Grace, given our local intelligence that tells us they are the 4 that we have commonly have difficulties with, and therefore we should focus and target our efforts there. There is no reason why we couldn't expand our audit and our quality priority further once we've got to grips with those that are most important given our data. Thank you.
Thank you, Grace. Thank you, Lucy. Thank you, Robbie. Okay, we'll move on then to the operational performance. And Sarah, you are Andy Parker today, so what would you like to pull out of the report?
Thank you, Chair. Yeah, just to pull out really, it's been another busy month. So May, following on from April, continued to be busy. One particular day we hit our highest attendance of 257, which is about 20% plus of what we'd normally see. So it continues to be busy, even though we're officially in the summer months. We are also having to work really hard in terms of the industrial action that we've seen and plan to see. And so there are 2 further periods of industrial action planned for this month, and the teams are obviously working hard to try and mitigate the risks that we face with that, including trying to minimise the amount of elective activity that we have to cancel as a result of it. So we've did pretty well on the last one in terms of minimising that, but obviously it's a difficult one for our teams to be able to cover everything off, but we do so to maintain safety for all of our pathways. We've also got the urgent and emergency care plan to deliver at 76%, so there's quite a bit of work ongoing with that. The plan is being pulled together, and there has already been quite a bit of action around that, which I think Andy may have alluded to in previous months, but a lot around the front door in terms of what we might do differently to improve our performance, which in turn improves our patient safety. I just wanted to pull out a little bit about discharge to assess. So discharge to assess is a service. We pulled a process together in response to COVID, did it fairly quickly, so that we could make sure that we had our acute beds available for anybody that needed to be admitted. So that was 3 years ago. So in the last month or so, we've come back together as a system to look at what's worked, what hasn't worked quite so well. Are we maximising the outcomes for our patients as best we can, and are we providing value for money? So we've really started to look in detail and evaluate what the last 3 years has told us. And we've had a really good workshop a couple of weeks ago with our partners, and when I say partners I mean local authority, some of our providers were also there, just to see what it is that we can do to improve the experience for our patients, but also make sure we're spending the money wisely. So that's a big piece of work for us in ops. We'll be bringing that through and reporting that through a D2A board, which will be a system board. So again, working really closely with our partners and providers, and that will be reported through to the integrated care executive so that we can monitor the progress through that. Just moving on to our elective activity, you know, despite the pressures, we are ahead of plan in the majority of our pathways, but obviously, as Jane's already alluded to, our cancer pathways you know, are suffering, and there's an awful lot of action going on to try and recover that. So I'll just quickly run through the 28-day fast diagnosis is slightly behind plan, particularly around radiology and histology. So I think this has been discussed before, but there is some action going on around that, including some deep dives to understand the issues. The 62-day standard, again, is behind plan. 28-day standard has impact on that, but there are some particular risks, again, around histology and radiology, mainly around vacancies, so work going on there. As I said, we were above plan in new outpatients, elective inpatients and elective day cases, excluding endoscopy for May. Jane's already alluded to the fact that there's a theatre productivity improvement piece of work going on over the next couple of weeks, which I think will be really useful and give us some really good information. And we're working with the Getting It Right First Time team around our outpatient productivity, so we'll be monitoring that closely. Diagnostics, just to pull out some particular worries, just to finish, in our echoes for our cardiac patients, mainly due to staffing. So there are some additional staff being sought to try and reduce the waits there for patients. And endoscopy, so we are seeing some waits for endoscopy. Some temporary staff have been identified and will be commencing in post later this month to try and catch up on that. And there's also some work ongoing to recruit into some general surgeon vacancies to try and improve the position with endoscopies. And I think that's probably about it in terms of pulling out the headlines, Chair.
Super, thank you very much, Sarah. Any questions or perspectives to Sarah? Ian?
Yeah, thank you, Sarah. A great report and well presented. I just wanted to pick up on the 78-week waits for elective activity, where I know we did a lot of work and got it down to, I think we got it to 0 at the end of March, and the numbers have kind of gone up slightly. Is that to do with cancellations for industrial action, or is there something else that's driving that?
Yeah, actually we're at 14, Ian, and then mainly 14, the complex orthodontic and max fax patients that we're working with Worcester to try and resolve. So yeah, we are currently starting at 14, and they're the reasons.
It's in a particular clinical area then?
Yeah, max fax and orthodontic. So okay. Yeah, fairly complex cases.
I understand. Thanks.
And any other questions to Sarah? Apologies if this is an unfair question, Sarah, but if I look at the elective work that we're doing, the inpatients and the day case, if my maths is correct, we're still running down year to date about 13% compared to 2019-20 activity when I add the two. What are the key reasons for that?
it's something that I'll probably have to ruminate on and get back to. Russell, yeah, wasn't given the detail around the elective pathways. I was just given the headlines, but Jane may have something to add here. She might be a bit closer to it.
I apologise. I didn't mean
Not
to
at
be,
all. Not at
didn't
all.
mean to be awkward. Jane, what would your perspective be? Why do you think we're running 13% down in total on 2019-20?
I mean, at the moment, I think it's primarily endoscopy, where we are a long way behind, and there's specific, individual staffing reasons for that, and as Sarah says, some locums being put in. So I think it's mainly endoscopy. Okay. Okie dokie. If we can just pop that in the minutes and just provide a bit more granular detail, but for our patients, obviously, and taxpayers, they want to see us getting ahead of where we were in 2019-20, and us being able to provide that granular detail is important. Thank you very much, Sarah. And we'll move on then to workforce. We had an hour session this morning, Jeffrey, on workforce, which was very good. Lots of reasons to be confident about the ambitious plans we have. Jeffrey, what would you care to pull out of your report?
Thanks, Russell. Well, in terms of the HR performance indicators, I'm pleased to say that we're still seeing a significant reduction, and things are moving in the right direction. So when you look at our staff turnover, our vacancies are going in the right direction. Sickness absence is now down to below 4%, which is amazing compared to over 8%, over the last 2-3 years. So we are definitely moving in the right direction, and I'm confident that we'll continue seeing those improvements in those key performance indicators. Our staff engagement campaign, the In Touch campaign, is going very well, and I'll be bringing back a report to the board in September. So we're getting some really useful suggestions and engagement from staff in that program throughout the organization. We continue to work actively with the Department of Work and Pensions and other local partners in terms of trying to promote job opportunities and careers within Wye Valley for local people. And our recruitment hub at the Franklin Barnes building is now operational, and we will be using that to really promote and drive through opportunities for local people. In terms of health and well-being, we are promoting the 1 Million Steps campaign by Diabetes UK, so people can get more healthier. And we are also supporting and encouraging our staff to participate in the NHS Pack Run, which takes place this Saturday. So it's still open to all board members if you wanted to join us in that. From an equality, diversity and inclusion perspective, we are supporting the South Asian Heritage Month, which is taking place through July and August as part of our commitment towards equality, diversity and inclusion. And Sarah mentioned industrial action. So we're working actively with senior managers and senior medical staff across the trust to make sure that we have good plans in place to support our patients. And finally, the workforce plan for the NHS has been published, as you mentioned, Russell, and we covered that in a board workshop this morning. And over the coming months, we'll be actively working on that with our group colleagues and ICS, our colleagues as well, to ensure that we can address the requirements of the plan. Those are the key things I wanted to cover, Russell. Happy to take any questions.
There's some fantastic things going on there, Jeffrey. Very well done. Questions and perspectives to Jeffrey? Andrew?
Yeah, it's useful, Jeffrey, to have the graph with both long-term and short-term sickness on it. And I thought the trend in long-term sickness is often a reflection of how staff are supported and the policies implemented quite rigorously. So I did think that was a particular indicator of some good improvement.
No, point well made, and I absolutely agree, Andrew. And any other questions or perspectives to Jeffrey? Lucy's on holiday in Santorini, I understand, at the next week, so she can run around Santorini a few times. Okay, so we'll move on then to the money. How are we looking on the money, Katie?
Thank you, Chair. So the pack includes the finance report for the first 2 months of the financial year, so taking us to the end of May. At that point, we were marginally ahead of the planned position, although I would urge a degree of caution in how we assess that, given the level of risk that we know exists within the plan and the scale of improvement still to be delivered, but clearly a pleasing place to be at this point in the year, but we can't be complacent. Indeed, I think if you look at the system and more broadly the regional and national positions at the same point in the year, we are seeing a level of financial pressure emerge. And as a system in deficit, we have got a series of enhanced controls that are now in place with a view to providing some short-term mitigation against some of that financial risk. Specifically from a Wye Valley perspective, so we've touched on nursing and medical agency. Spend did increase ever so slightly in the month compared to April, but still is running at a level lower than last financial year, linked to some of those targeted actions that we've been taking, which is pleasing. My biggest worry on the finance side is around the cost and productivity improvement. So we've under-delivered in month. It was non-recurrently mitigated fortuitously, and we are really focused on ensuring that that programme is fully identified as soon as possible, and we've strengthened the governance and oversight around it to give us the best chance of doing so. Just picking up the point on activity volumes against 1920 and particularly electives, the not delivering fully to plan does present a degree of risk around the inclusion of elective income within our position. But what we also see is that when we look at the value of the activity we are doing, it's driving a better performance against 1920. So there is a case mix complexity to just looking at the pure volume numbers. In terms of capital and cash, there are no exceptions to report this month, but just to note that following the discussion last month, we did submit a request for cash support through Q2, and that's just been worked through with the national team now, so that process is working. I'm happy to take any questions, Chair.
Very clear, thank you as ever, Katie. Questions or perspectives to Katie? Andrew?
Yeah, when I read it, I wondered whether there were more reasons to be concerned than last month. So I just wondered if my perspective was correct.
Just before you reply, Katie, we're obviously now in July, so you'll have a sense of, for example, on agency usage, what June is looking like. So are you getting more worried as Andrew sort of fears, or are you feeling equally worried?
I think I'd say I'm feeling equally worried. So if that didn't come across last month, then perhaps I needed to have been more explicit last month, Andrew. I don't think I'm feeling more worried than I did. I think agency broadly, those actions that we've already taken are showing traction and are sustaining. We need them to further step down, so there's still a way to go, but we've got that traction on what we've already started. We are though seeing those pressures that we thought we would see in terms of some of the non-pay spend from an inflationary perspective, our ability to deliver in full the level of efficiency that we've planned to deliver, and really the need to deliver the activity plan that we've set ourselves. So there's a lot to be done.
Andrew, just to give a level of reassurance, certainly when I compare the what I would regard as a grip through the Finance and Performance Subcommittee across the Foundation Group, I think Wye Valley has the best functioning, most effective F&P meetings I see across the Foundation Group, and that's in no small part, Katie, due to the way you chair them, as well as the efforts of colleagues. But as you say, we have got a mountain to climb. Any other questions or perspectives to Katie? Okay, colleagues, we'll move on then to items for approval. And just to make sure we haven't got any declarations of interest on items approval, please raise your digital hand if there are any declarations of interest you need to make. Okay, so the first one we've discussed in private board substantially. Jane, if I maybe just introduce and you add on Glenn's behalf anything further that you would like to. Members of the public are aware that Wye Valley is part of the Foundation Group, and the Foundation Group currently exists with 3 full members, which is Wye Valley, South Warwickshire NHS Foundation Trust, and George Eliot Hospital up in Nuneaton. The definition of a full member is that we share
a common chair in Chief Executive in myself and Glenn Burley across those 3 sovereign boards. Worcester Acute Hospital has been an associate member of the Foundation Group for about the last 18 months, 2 years. Worcester Acute Board have requested to become full members, partly as a consequence of their Chief Executive resigning to new pastures. So there is a request from Worcester Acute to become full members. As part of the constitution of the Foundation Group, effectively, every member, a full member of the Foundation Group, needs to approve a joining of a new full member. The George Eliot Board, the Swift Board have both approved Worcester joining as a full member. The purpose of this paper is to seek board approval for Worcester to join. As I said, we have talked about it substantially in private sessions before, looked at the different risks and opportunities. Jane, is there anything you'd like to add to my overview?
Yeah, there's a couple of things I wanted to say specifically from a Wye Valley perspective. So I think it's beyond doubt that the 3 existing trusts, but specifically Wye Valley, have benefited from group membership, and we've enjoyed a enhanced improvement journey that otherwise would not have been possible. And I think there's 3 areas that make that different. The first is leadership, capacity and capability, and I think that's from Glenn and from Russell, and that's, I think, direct support to certainly me as managing director, the other directors, and to the board, but also that regional and national profile and voice. I think we very much benefit from that. The second is obviously the benchmarking, sharing best practice that makes a difference at the ground level, at specialty level across, and that'll only be enhanced by Worcester joining us and having another partner to gain their best practice from as well. And the third area is scale. And then I think very particularly for Wye Valley, it will enable us to find those innovative solutions for our fragile services that I think otherwise would be difficult to negotiate, and we've found that it's been difficult and sometimes downright impossible to find those innovative solutions, and it will enable us to do that. And I think that's going to be absolutely of benefit to the population that we serve and the population that Worcester Acute serves as well. So I'm absolutely in full support of Worcester Acute joining the group.
Thank you very much, Jane. Are there any questions or perspectives from colleagues? Frank?
Yeah, it just seems to be an obvious way forward. I'm very much in favour, but NHSE have got views on this. Have we heard anything from them?
I think NHSE are very supportive, and they're, if you like, the final bit of smoke comes out of NHSE next week. So. But there's absolutely no reason to think they aren't very supportive. Thank you, Frank.
Thank you.
So if you're not happy to approve, just let Frank take his digital hand down. If you're not happy to approve, could you please raise the digital hand? Duly approved. So we look forward now with confidence to Worcester Acute becoming a full member on the 1st of August. We then move on to the NHS joint forward plan, which we've all had the opportunity to read. Thanks to colleagues at system level as well as Alan for a lot of involvement in this. Alan, what would you care to pull out?
I'll just summarise really why this is here. As you say, this and the covering paper has been developed over quite a long period by colleagues at system level, with input from myself and some of the colleagues around this table today. It's going to all the trusts within the system for endorsement. The approval actually happens at an ICB level, of which of course we're a member. Every ICS is expected to have a 5-year joint forward plan. NHS England are very clear about that, and it's about the delivery of our strategy as a system. It also includes the joint local health and wellbeing board strategies that have been agreed recently, and addresses many of the duties of the ICB and provider organisations. So there's the main document here and 3 appendices. The main document outlines the shift to a more preventative approach across as a system, that kind of left shift of caring for people or looking after people in the right setting, and the improved quality of care that people get on the back of that, and also the reduced cost of care, not caring for people in high cost environments. And that's a big theme in this document. Appendix 1 sets out some of the high level plans for priority services. So there are a set of priorities set in here, quite a long set of priorities, I would say, but against each of them there's a kind of very high level plan, system-wide plan for that. And Appendix 2 looks at some of the key supporting themes like IT, those kind of cross-cutting themes that support the change that we want to make. It's a comprehensive document, and it sets out an ICS-wide response to the local health and wellbeing board priorities at both places in Herefordshire and Worcestershire, and then the common themes that are across that. And also I'm quite pleased that it actually recognises the role of Herefordshire's place-based collaborative, the One Herefordshire Partnership, as being one of the main delivery arms of this approach. And I think that's really, really important. So it really consolidates all of this into an ICB view. It's trying to do all things for all people, as so often these documents do. And the next step, finally, is delivering a summary of this that's more digestible for the public and for staff, and developing a medium-term financial strategy that underpins it as well. That's all I'll say at this point. Thank you.
Thank you very much, Alan. And like I said, thank you for your hard work on it. So the purpose of this is for us to approve it, because all the providers need to approve. Questions or perspectives, Nicola?
Yes, so thank you. You answered my one question there, Alan, that was it going to be in a bite-sized format that could be shared, not just with the wider community, but actually for the people that work in these organisations and how they fit in. Because I think it was a really good piece of work. There was some really good detail in there. But if it's being shared wider, there's so much breadth. When looking at those priorities, I was thinking, where's the depth that you can then follow through, and they only have one, and I did have one question. Is I noticed that, and I don't know whether it's semantics or is there something fundamental that I didn't get from it in terms of the Hereford and Worcester health and wellbeing strategies. They were different, and I get it, 2 different counties, but when you looked at the words, they were almost the same. That I was reading it both ways and thinking, are they different, and is it a shame that it almost wasn't one, because there's more similar than there is different?
Well, of course, you're absolutely right. They are similar but different, and worded slightly differently, but often say similar sort of things. And I think that just represents the 2 different sets of thinking at each place. And I think there's an understanding here that we let's not forget the Health and Wellbeing Board is part of Herefordshire Council, and they're a part of our ICB as well, and that it's got to reflect what those board members think is right for their place. So it's just recognising the differences there, even though there are a lot of similarities. I agree.
But I just say it was a starting position, isn't it? And maybe when we see this updated, or when we see this in the future, if they are the same and we're aligned, maybe we'll know that we're in the right place, because there's, as I say, there'll be more similar than different.
Yeah.
Thanks.
Need to pick up the speed a bit, guys. Ian?
Yes, it's a good document, actually, Alan. It's clearly set out, and I enjoyed reading it. My only comment would be kind of presentational almost. And while the Herefordshire work is referenced, and there is lots of brilliant work going on in Herefordshire, I couldn't help thinking if I was a Herefordian reading it, I might kind of struggle to find that bit. And so there would have been something for me about actually trying to give some prominence, almost kind of starting with the local and then going to the system, just in terms of local people understanding how we're part of the bigger system, but actually there's a focus on things happening locally. But you know, as you said, it's trying to be everything, you know, all things to all people. But I think if you're a local Herefordian reading, you might struggle to kind of see where it fits in with everything else that we're doing. Yeah, no, I think that's a more profound point that might be recognised on the starting of it, Ian, because it is, you know, the starting point of integrated care was place. And yet it almost appears inverted. So I think that's a good challenge for the future. We'll bear with that. So again, apologies, but we are running a bit late. If you're not happy to approve this, would you please raise a digital hand? Okay, duly approved. Thank you, Alan. And then we move on to some items for noting and information. And if we could rattle through these, I'd be grateful. But before we do the first, which is the Freedom to Speak Up annual report, Den McPherson, I know this is, I think, your last day with us before you retire. So on behalf of the board, enormous thanks to you for all the work you've done for us. We really do appreciate it. So Den, what would you care to pull out of the Freedom to Speak Up annual report?
I think firstly, the good news is that the trust has invested ring fence time for my successor, Joe Sanford. So we're now up to 3 full days, and that will include some Civility Saves Lives works, which will carry on, which is really good. You know, the work of Chris Turner is fantastic, and we pull on other experts across the world really to do that. And over 400 staff attended a session, whether it was trust-wide or bespoke for a department in the last sort of 8 to 10 months. And that pulls back to the recommendation in the report that we do push module 2 of the e-learning, which is the listen up, because if we're really wanting our staff to speak up, we need our managers to know what is expected of them when they listen up. And just a quick, in the data return section, it states there that the report was due. It's come out this week, the next report, and it states 25% increase nationally in speaking up events to the Guardian, so that's been reported. Almost a third include an element of inappropriate behaviours, which is sort of reflecting where we were before last year, and a quarter about staff safety and well-being. And again, that cements the lessons of Civility Saves Lives, freedom to speak up, and as you alluded to earlier on in the meeting, Russell, you know, really encouraging our staff to speak up in still difficult times. And very quickly on the lessons learned, I think it can be simple, a lesson learned. You know, you just ask for help from your staff, and there it comes. It's there, you know, and that one really did solve quite a difficult problem around the use of English language in the workplace. Then, just to say that very quickly. Our team of champions is really important resource, and Joe will continue to try and recruit from areas that we've naturally lost through you know, people moving on, or where there are gaps, and that's definitely on her horizon. The handover timely report came out this month about how the National Guardian's Office expects trusts to manage handovers, if certain things including handover times, and I can say that what was put in place for our trust with me handing over and supporting goes well beyond what is expected by the National Guardian's Office. So thank you for the trust for putting that time in. It gave Jo good time to get the support and then get her feet embedded and get out and known across the organisation. And as I said in many TMB meetings, your visibility is definitely aligned to the speaking up events that you have, whether it be to us or as we advertise that it's through the management structure first. And just thanks to the execs for all your support over the last 4.5 years. It's been much appreciated, and I know that all of you, including Glenn, know that when I come to you, I do need your help, and I always get it, which I really have appreciated, and I know Joe does too. So thank you.
Thank you, Dan. Any questions or perspectives to Dan? Jane?
Just an enormous thank you. Jen's been absolutely brilliant in taking on what Christabel started and then really developing it, and is such a person of trust in the organisation. So just a huge thank you, Jen.
Thank you. I've thoroughly enjoyed it. I'm going to miss it.
And Ian?
Well, and I wanted to add my thanks as well. We've worked closely over the last few months, Denise, and also thanks for managing a good handover as well. Joe's going great guns now, as I'm sure the board will find out in due course. I did want to ask, is there anything you'd want to leave us with in terms of actually what we could do to improve staff's ability to speak up?
I'm very much an advocate of and I've talked about this with HR people as well, is having peer advocates, peer messengers, second messengers, whatever. There's some fantastic statistics out there that if you nip things in the bud, so if you have that conversation over a cup of coffee, that especially with behavioural things, if you've got that second messenger and somebody, you know who it is, and they're coming to see you, you know they haven't got their own agenda, they're coming with facts where you have possibly, without knowing it, really upset somebody or done something wrong. And that then, you know, you're not saying you must go away and apologise, but then generally there's some studies out there that said it's gone from tens of thousands of people, and you have that first intervention and that basic intervention, and it can go down to a couple of thousand that offend, if you like. And I think that's something I've talked to Joe about, and really I think keen with some HR people to get that into practice, to save things go into HR. You know, they're handling a lot that doesn't need to be handled by them, I think.
Dan, thank you very much. Enjoy your retirement. You go with our love and much appreciation. You take care.
Thank you very much, everyone.
We are now running substantially behind time, guys. So the patient experience quarterly report, Lucy, what would you care to point out?
Thank you, Chair. I'll be very brief. So not a detailed report this month because of the transition from Datix to InPhase, so no themes to pull out. The family and friends text is working really well in terms of the number of responses we're getting, and it's really positive to see the majority of those are positive. However, it is disappointing to see that we've got some attitudinal elements to work on and some communication elements to work on. So I think the detailed analysis from each of the divisions so that they can focus on their specific issues is really important, and they're coming to the Patient Experience Committee over the course of the next couple of months. We are disappointed that the link to our local survey hasn't had any uptake via the text messaging service. So we really do welcome the volunteers doing face-to-face feedback from our patients and service users, because we know that that's more timely than the national reports that are always a year out of date by the time we receive the results. And finally, from me, just that I'm really pleased that the Patient Experience Committee is back up and running with a new focus. What we really need, and I know it's difficult, is some medical engagement with that, given some of the feedback that we've had around that particular group through the national survey and through our family and friends texts.
Great, thank you, Lucy. I'm sure that's being heard by colleagues. Questions or perspectives to Lucy? Okay, keep us brief, please, Lucy. Salma, nice to see you. Amy, nice to see you. So the maternity services quarterly report. Lucy, are you going to introduce this, or are you going to go straight to Salma and Amy?
We can go straight to Salma and Amy. I just thought it was important. This is Salma's first time at board. Salma's our clinical director for maternity services, and I thought it was important to have the MD to.
Okay, I found this on the web for clinical director from.
Sorry, my Siri is talking to me. It looks, Amy, as though you're on holiday in Ibiza or somewhere.
I wish I was in Ibiza, Chair, but I am not in Ibiza. But I have had some technical issues, so apologies from me that I don't have the appropriate background today, and it looks like it's flickering from my side, so apologies if you can see that.
No,
I'll start the report if that's okay, particularly because you're running behind. I'll move through it and consider it as read. Points to pull out really, this is obviously our Q4 report, which is quite late in the day, just because of the reporting period. We've included April and May, but we haven't completed Q1 at the time of reporting. So we follow the 4 key questions: how are we safe, how do we know it, what's new and different, what we're especially proud of, and what are we worried about and what are we doing about it. In terms of how are we safe and how do we know it, we had 3 new serious incidents reported in Q4, and those cases are outlined in the report. I'll consider that they've been read and happy to take questions at the end. It's just worth noting that it's really important that we report this particular section for our compliance with CNST Year 5, so it is important that board are cited on this information. During the reporting period, there were 2 cases reportable to Embrace, and those cases are outlined, and those women and families are being supported by the bereavement midwife, and we've also engaged with a new service called Petals, which is a counselling service that women are also able to access. In terms of our complaints, I think this is quite a positive. So as we drew to a close of last year with Q4, we noted that over the course of the year there'd been a marked reduction in the number of complaints received by the service. We'd actually had 10 complaints across the financial year, which was a reduction on 19 from the previous year. Whilst we're disappointed to receive complaints, we also recognise the value and the gift that they offer in terms of us to be able to learn and progress our service. So we're really grateful to the women and families for coming forward with their complaints. Compliments wise, we didn't have the data available for Q4 just due to our changeover in systems, but during April we had 17 compliments and a further 16 in May. Our patient safety midwife does a walk around every day, and we're receiving lots of really positive feedback from the women, and this is echoed through our MVP as well. What's new and what's different? So we've got some changes to our training compliance. It dropped slightly to just below 90%, but remains above 80%. CNST is very clear, you need to sustain above 90%. However, it's what's not clear in the technical guidance is whether that's an average across the year or whether that's month on month across the year. Collectively, as a group of directors of midwifery and heads of midwifery across the region, we've raised that as a query, and the regional team are kindly supporting us on feeding that back to the CNST team, and we are waiting for confirmation of what exactly that technical guidance looks like. CNST has been launched for Year 5, and we're just undertaking a gap analysis. Obviously, most of you will know by now because we have shouted loudly about our proudness of achieving the full compliance during Year 4. Service user involvement, so we've had a lot of improved work with the MVP. In fact, we've been asked by the LMNS to support Worcester at the moment with their MVP services, just because of some of the things that we've done that have increased engagement. One of which we're just launching is a roadshow where our midwifery team and the MVP are getting out to the harder to reach areas, and the MVP were really fortunate to have secured some funding through the LMNS, so we're now doing things like picnic and stay to encourage mums and their children to stay to be part of the MVP sessions. The workforce review, so this comes under continuity of care update. So we have completed the initial steps of our workforce review, which were undertaken with our independent consultant midwife, which was funded from continuity of funds from the LMNS. This has enabled us to commence the first building blocks required to develop a continuity of care plan. We're expecting a workforce plan to be complete towards the end of July, and this will follow trust process in terms of us presenting this and any asks that that plan might have. So we should see that in the coming weeks. In terms of what we're proud of, so always proud of teamwork. I think the team continue to pull together and support each other. However, we are noting marked improvements on our maternity rosters, which is obviously improving how the teams are feeling about coming to work as well. And that leads me on to workforce and staffing. So please note the significance of the shift in workforce and staffing to the what we're proud of section, rather than the what we're concerned about section. We have a current vacancy rate of 2.4 whole-time equivalent, which increases to 9 whole-time equivalent with maternity leave. We have welcomed some midwives over Q4, and we've had some further resignations, so it kind of keeps us at a stable vacancy rate. But we did have a very successful trust recruitment open day, and we were delighted to have appointed 12 newly qualified midwives during that period who have all accepted placements with us and will be joining us in September. So we're really excited about that and just firming up our plans to make sure that they're really integrated well and given good opportunities for an induction. I am nearly there. And then just with our international recruits, just an update on the report, because at the time of reporting we said 2 had passed their OSCEs, all 4 that we've taken on have successfully passed their OSCEs, and we're really looking forward to holding a celebration event soon, because whilst the trust is established in international recruitment for nursing, this is a first for midwifery and a really big milestone that we're delighted to have taken part in. So then in terms of caring for you, this is another, I think, nice milestone. So International Day of Midwife this year saw a sign up for the Caring for You Charter, and this outlines our commitment to providing good working facilities and good environments for our midwifery workforce, to help with retention and help with the morale and the experiences that they have on a day-to-day basis. So we're really pleased with that. And we had a series of celebrations across the whole month, which had a great impact on staff morale and boosted service user engagement. Just take a second just to acknowledge one particular highlight of that for me, which stood out. On our maternity Facebook group page, we celebrated a day, each day we celebrated a different midwife, and on about day 26 we celebrated a particular midwife, and a dad commented and said, "My wife has been waiting for your name to come up and waiting patiently to celebrate you." And I thought that was such a lovely sign that for 26 days someone's been actively engaging, so that was really, really lovely, and such a boost to the midwifery team. What are we worried about and what we're doing about it? So I've touched on the diabetes service throughout the report in a different section as it was part of our learning. We'd already started a piece of work around diabetes and improving some of the concerns that we've got around how the services run. Mostly it's around just quality improvement rather than anything that's causing any significant risk to anyone. It's not featuring on our risk register, but the Saving Babies' Lives Care Bundle was just launched at the end of May, and this has helped because there's now a new element as part of that bundle which outlines really clearly much of the work that we're already undertaking, but it gives us a structure and a sense of coordinating it that is welcomed. Since the publication of the final Ockenden review, I feel that there's been a lot of focus on the first report and the 7 IEAs. Much of our work with the LMNS and the ICB is around demonstrating our success and our compliance with the first 7, but actually we have been on a hold kind of basis waiting for the single delivery plan that launched in March, and we've since in May received a technical guidance to accompany that. I have asked the LMNS, who kindly agreed to support us now in laying out the evidence that would be considered as appropriate to show our compliance against the 15, and that gives us a better sense of something to work towards. So that work was due to go underway and has been temporarily delayed due to a CQC inspection.
Amy, sorry, Amy, we do need to watch the time because I want to give Salma the opportunity as well.
Fab. Our final thing, Elizabeth, the final thing is our maternity triage still means 20 on our risk register, and I'm happy for Salma to come in now. Thank you.
Right. And Salma, welcome. Delighted to have you with us. What perspectives would you care to share with the board?
Well, thank you for having me. This is the first time for me to be in the board. I think I took over the role of clinical director in November. Every day is challenging, but we have a very strong support from the team. I work closely with the head of midwifery or Directorate of Midwifery, that's the real name, and we have a support from my consultant colleague. We have a very positive attitude towards our staff, an open door policy to listen to their concerns. We know our weakness, and we're trying to improve the service which we provide. So, yeah.
Thank you, Salma. You know, being relatively new, is there any more support you would like the board to be giving you? And the same question goes to you, Amy. Do you feel we're not giving?
I think from
sure.
my perspective, go on,
Yeah.
Salma, go on.
No, you go on.
I think from my perspective, Russell, I mean, obviously when I took the role, one of the things that was attractive was a stable board, in terms of people being in post for a long time and having that stability. I've worked in trusts where there's a quick turnover and a quick turnaround, and actually that offers a huge degree of challenge. I've felt, you know, really like my voice is valued, particularly in terms of the triage risks and being able to articulate that and be heard and be supported in coming up with plans to mitigate risk. So for me personally, I feel well supported, and obviously, Sam, I won't answer for you, but I know you've been having some support from the LMNS as well, so you might want to consider that.
Yeah, so we regularly meet with the LMNS, and we have our committee with them, and we feel quite supported. We investigate any incidents. We promote training, and I mean, basically we are quite engaged with them, and we have a regular feedback, and we report to them.
Okay, great, super, thank you. Really conscious of time, because we're running about half an hour late now, guys. But questions and perspectives to Amy or Salma, Ian?
Yeah, I just want to pick up the triage issue, which you highlight in the report, and actually it's in the risk register as well, which we come to later. And the report talks about there being a kind of plan, I think, to resolve it in a state's plan, although that's not mentioned in the risk register, and there might just be the kind of timing thing there. So I just wanted more clarity of what the plan is and how soon that might be resolved. And that might be a question for Alan, actually, rather than either Salma or Amy.
I'm happy for anyone to answer.
I can say that it's in our capital programme, and Sodexo are working up a change notice that's been submitted around that at the moment, so it's work we'd expect to do this year.
Okay, good.
In the current year. Okay, that's helpful. Yeah. Thanks.
Okay, Amy, Salma, thank you all very much for your hard work. No, the challenge is always babies are coming, and it's a joyous thing to be involved in the birth of a healthy baby. So thank you very much. Please pass on our thanks to all of your colleagues, and we look forward to seeing you next time. To board colleagues, we need to pick up the pace. So the security update report, Alan, anything you particularly like to pull out?
Just one thing. This is a response to a question we actually received from a member of the public, and therefore I think it's quite important, and it gives us an opportunity just to highlight the improvements we've made that started with the Operation Nightingale work a few years ago. We've continued that with the security group ever since. The only thing I will pull out of this is the introduction of a new security service that we've had in place for a couple of months now. That's done through the PFI contract and is provided by Sodexo. Too early to say whether that's had much of an impact, although anecdotally staff are reporting that they feel safer on site. And I think I don't know whether it will manifest itself in a reduction of incidents, because we are encouraging staff to report incidents, and not necessarily a good indicator. I think that the right indicator here of effectiveness is the staff survey, which is probably a better barometer about whether staff are facing incidents of violence and aggression and feel safer at work. So that's all I was going to highlight here.
Thank you, Alan. Any questions or perspectives to Alan? We'd like to make a general statement to members of the public. There is clearly a very significant increase in violence and acts and aggression towards members of staff. It is totally inappropriate under any circumstances for my staff, our staff, to be faced with either physical or verbal aggression from a patient or family member, whatever they feel the provocation is. All of our teams are trying to do their best for you and for your family or loved one. And in particular, a 50% increase, and I hear the point on the encouragement to speak up, Alan, but a 50% increase in racial abuse is frankly unacceptable. We, at the very heart of our trust values, have two key mantras: be kind and be polite. Be kind and be polite if you're a patient or a family member. Be kind and be polite if you're a member of staff towards one another. Alan, please keep us updated on that, because the trends are, in my view, very worrying. But I can't emphasise enough, members of the public, you do not have the right to physically or verbally abuse any member of the Wye Valley Trust staff. The Division on Operational Risk Register. Erica, what would you care to pull out?
Sorry, Chair, struggling to come off mute. I'll take the risk register as read. There is a lot of work going on with risk at the moment. It was very timely with the move to in-phase, so a lot of housekeeping. We've rewritten the risk policy, and there's now going to be training provided to make sure that the risk scores align with the risk appetite that was agreed by the board some months ago, and that we don't have, in terms of violence and aggression, for example, people's risk tolerance might be different. So being very clear about how we score and describe registers. So this is a live document. It's ongoing. I recognise that this risk register has changed already since it was published. So it's an ongoing piece of work.
Okay, thank you very much, Erica. Questions or perspectives to Erica? Erica, just as something to take away, I do worry that we're not emphasising the risk and the consequences of the junior doctors' strike or the consultant strikes, the ongoing industrial action sufficiently high. At the end of the day, we can do phenomenal work, but if we're continually being hit by strikes, it's a nightmare for Andy, Sarah and all of the team to actually cope with that. So can I ask you to take that away? I need to push on, Erica. Thank you. Preparing for winter. Sarah, what would you care to pull out?
Yeah, so well, I've seen the papers being read. So this is about closing the gap in terms of winter approaching, needing to house additional patients. We don't want to be looking after them in the way that we did last winter in unconventional care bed spaces, which is essentially boarding on wards. There are 8 schemes detailed within the paper, which is how we're trying to bridge that gap between not having enough beds to accommodate the patients that are coming in. The schemes are all vary really in risk. We've tried to detail the level of risk within the paper, but essentially the paper is just highlighting those schemes, the risk that we've assumed with them, where we think we'll end up in terms of the gap in the bed occupancy over winter, and just a note in there around the use of Gilwan. So, I mean, I'll take any questions and assume you've read the papers.
Thank you, Sarah. Any questions or perspectives on the winter plan? Sarah, just to educate me, but I'll let Jane go first. Jane?
Yeah, I think first of all, just to say, I think it's a really good piece of work in terms of trying to attach, you know, what we think the improvements be, how many beds does that relate to, and so you know, there's a lot of assumptions based under it, and you know, it's a plan, so it'll inevitably be wrong, but broadly, I think it's in the right sort of place. But you know, more than anything, it highlights a financial risk that we don't have funding for Gilwan for the second half of the year. And so all of that work that we're doing over the summer in terms of improving emergency flow and discharge pathways has got to be big enough. It's got to be bigger than it's currently planned to be, so we mitigate that risk. And so we've got a lot more work to do yet to be able to do that. You're on mute, Russell.
I imagine that was Katie's point, as her hand went up and then went down. So the thing I was going to ask was, I assume you talk to other COOs who are doing exactly the same type of analysis across the foundation group to make sure that we're sharing opportunities as well as learnings, yeah?
Absolutely,
Super.
yeah, and actually we're meeting them in the morning from the group, yeah.
Super. And we'll look forward to Worcester Acute colleagues joining that. So we're on to the committee summary reports. I'll take the Foundation Group Strategy Committee of the 23rd of May as read. Any questions on that? Please raise a digital hand. Okay, can't see a digital hand raised. So the IC, the Integrated Care Executive, 2 meetings of May and June. Francis, what would you like to pull out?
Take the reports as read. Colleagues will remember that we had hoped that by now we would have had the signed memorandum of understanding with the ICB and with our One Herefordshire partners. We're very nearly there, so anticipate being able to bring that back next time, and that gives even more opportunities to integrate and align our services. And for members of the public, the patient story that we had this morning, and we were pleased to welcome colleagues who described how our teams being co-located, working together, having access to virtual and broader clinical expertise, are doing all the things that we aspire to, which is having very patient-centred care delivered at home, unless there's an absolutely critical clinical reason why people need to be in hospital. So keep on doing what you're doing.
Thank you very much, Francis. Any questions to Francis on the Integrated Care Executive meetings? Thank you. So we'll move on to the Quality Committee of the 25th of May. Ian, anything you'd like to pull out?
Yes, I just wanted to highlight the comment in there about virtual wards. As we've just said, actually, they're an exciting development in terms of people being able to receive the equivalent of hospital care, but at home. But actually raise questions about how to ensure that we're giving good quality services and what are the safety implications. And we've asked for a further discussion back at Quality Committee. So it's an interesting development in that area.
Thank you. And any questions to Ian? I think the other aspect, Ian, is it better to have virtual wards with one bundle of risk, or people in corridors with a different bundle of risk? And that's the type of issue I think over time we need to make sure that we're allowing the acutes to flow, but we're getting the risk management profiles right in the virtual ward environment. The Audit Committee of the 16th of March. Nicola, anything you'd like to brief us on?
Just want to say, you'll notice it's quite light on internal audit reports. There were quite a few behind. So what we did is we did a catch-up meeting in May. So there'll be a separate section of minutes with about 7 more finalised IA reports to come. So that's all really. Thanks.
Okay, super. Any questions for Nicola on that Audit Committee? And then I think we're on to the Quality Committee of the 27th of April, which has got your name next to it again, Nicola.
Yeah, nothing to add to that, thanks.
Okay. Any questions on the 27th of April Quality Committee? So, any other business, colleagues? Could you please raise a digital hand? Andrew.
Yeah, Chair, you asked me to raise the issue of Director of HOOPL. Most of us were in the workshop this morning, and you had a bit of an introduction from Simon, came in from IT about what HOOPL is. It's a company limited by shares, and the shareholders being the council, Wye Valley Trust, and now Lincolnshire. They are small shareholders. There are also some unallocated shares. HOOPL's got a turnover of about £23 million, staff 560. Range of services, IT, financial services, payroll, building services, and actually some care services now, social care services. Our formal relationship with them really is around IT, but we are required to provide a director to be a director of HOOPL Limited, and I've had the privilege of being that for the past 8 or so years. And in discussion with the chair, he's nominated Nicola to take over from my role when I leave. Well, I'm leaving in September, but at the end of September, Nicola's been doing some familiarisation, but also through me making important decisions for HOOPL. So I've kept her in the loop and included her in some fairly important decisions. There's an end of year meeting for HOOPL end of July, which I will chair, and then from the 1st of August, Nicola, the proposition is Nicola takes over my role.
Thank you, Andrew. Nicola, are you happy to volunteer?
Absolutely, very big and very well respected shoes to fill with Andrew. He's so very well thought of at Hoople, but I'm really excited to be stepping in. Thanks.
Okay, great, super. Thank you very much, Nicola. Okay, so I think then if there's no any other business, we want to questions from members of the public. And Chris Lewandowski, those of us who have been around a bit know Chris from times past, has given 4 questions. So I will rattle through them and colleagues will help on answering some of them. So the first question is, does the Wye Valley Trust Board intend to return to live face-to-face public board meetings? If so, when? Chris, the answer to that is it's not a priority for a number of reasons. You'll be aware that today we are live streaming onto YouTube, but I think one of the arguably the few good things that came out of lockdown was a realization of the enormous productivity and ecological benefits of having more meetings digitally. So as an example, even in today's meeting, Katie wouldn't be able to join us because she's having to be elsewhere if we had a physical meeting. And if we did have a physical meeting, the carbon dioxide implications of physical meetings now, given the geographies that a number of us live in, would be very substantial. And the other advantage is that I think that what digital does allow is far more inclusion for people who are maybe less mobile, maybe more geographically isolated, to see the work of the board in action rather than having to come, as in the old days, into the site. So Chris, much as I miss seeing you and having a cup of tea and a biscuit with you, it's not actually a priority for us to go back to physical board meetings. The second question is, it's unfortunate there is a server running time error that prevents members of the public for accessing the Trust board meetings for today's meeting. Actually, I think that was resolved earlier, Chris, according to Erica. I do apologise for the inconvenience, but we will make sure that doesn't happen going forward. Third question is around stroke services, and I think Robbie, you're going to help me on these, please. The first part is, does the appointment of a new locum consultant for stroke services mean that there is now 24/7 consultant cover for stroke admissions, including weekends and nights? Robbie?
Yeah, so we've always had 24/7 cover, not on site, but we've always had access to an out of hours rota that's networked currently across the southwest, so that any new stroke patients that come in are decided whether they need thrombolysis or not through that network. During the day, we have face-to-face consultations, and our performance around access to a specialist stroke consultant is very good on those SNAP scores that I think we mentioned earlier. So that's the answer to that. So whether we've had 1 or 2 locum consultants, we've always had that access, and we're continuing to look at new models of care, particularly with Worcester.
Thank you, Robbie. And like you say, our SNAP core at 4 is very good. The second part of the question is, some Herefordshire and Power stroke patients living in more rural areas have a much longer transfer time to reach hospital than is the case in more urban areas of the West Midlands. This is primarily a West Midlands ambulance service problem, but as such, travel time can be crucial to stroke patients. It is a concern. Do Wye Valley Trust staff attempt to monitor the detrimental effect of long transfer times for stroke patients? And does the board engage with WEMAS to try and improve these transfer times and attempt to meet national guidance response times? Has there been any progress in this matter? Robbie, I'll have a few comments, but you go first.
Yeah, so the ambulance response times are largely owned by the ambulance service themselves, although it'll be impacted, of course, on some of the things that we can do about releasing ambulance crews earlier from the emergency department, which we work closely with them around doing that and improving those processes. terms of the average weight, the last information I've had is average response times for category 2, which stroke falls into, so they're not the sort of very near death ones, is about 36 minutes. We have to hit, I think, 90% within 40 minutes. So clearly there is some work around that. Our average conveyance time from call to arriving at Hereford is somewhere around 100 minutes, and clearly that may impact on some of the stroke outcomes, and it's likely to be longer for those in rural areas. But the nature of our geography is always going to make that challenging. We do link in with them at our ICB stroke board, and we look at that ambulance data and try and work with them in terms of whether we can get anything, any further improvements. Of course, some of the impact is also on delays of patients calling for help, so we need to do some more public health work around that as well. And then in terms of that ambulance conveyance, there are other models that are used elsewhere, but not one that we want to take forward because it's very tricky and the safety issues, which is actually, for example, thrombolysis on the back of ambulances, but that's not a model we've wanted to move forward, as the evidence around that is not great. So the summary is, yes, we're working with them, yes, we keep an eye on it, and we'll continue to try and model that, but ultimately the ambulance services have some responsibility around that themselves.
I think, Robbie, and correct me if you think I'm wrong, please do, because I'm not a clinician, but for me it's self-evident. If anyone lives in a rural location, a long way from an urban area, it will always be more difficult if you have a stroke or a category 1 incident to get an ambulance to you. If you want to get to a hospital quickly, at its simplest, all of us should live next door to a hospital. But if we all love the benefits of living in rural locations, but there is a consequence of that, which even despite the best endeavours of West Midlands Ambulance Service, that is just an issue of living in the countryside. And certainly this is my personal view. I've always said to my wife, if she thinks I'm having a stroke, put me in the car and drive me straight away to the hospital. Don't phone the ambulance. But that's just personal advice I give my wife. And the final question is, how well are the new Sodexo security arrangements working? Has there been an increased decrease in verbal or physical assets upon Wye Valley staff? I think we did touch on that earlier, Chris. And so I think we've covered off on that. You do say at the end of your note to me, in these troubled days for the NHS, I'm reluctant to ask many questions of the board. Please don't feel that, Chris. We are here to serve our citizens. Any members of the public can ask us any question at any time, and Jane, Glenn, myself will endeavour to answer them in between boards, but at the board we're very happy to answer them, and we'll take the time to answer them as we have done today. Members of the public, that's the end of our board meeting now. We have a 3-board meeting foundation group meeting on the, I think it's the 4th of August, might be the 2nd of August, where we bring together all 3 boards. You're very welcome to come and join us then. In the meantime, take care, enjoy your gardens, enjoy the countryside, because we're blessed to have it, and I look forward to seeing my executive colleagues and non-executive colleagues in the confidential board in 5 minutes. Thank you very much.